Hi everyone, my name is Kunal. I'm a last year medical student, and today we'll be discussing about the differential diagnosis of hypokalemia and metabolic alkalosis. We will study this differential diagnosis using a clinical vignette. So let's start. A 16-year-old female come with a sports instructor for a routine examination. After examination, we found out that her BMI was 18 kg per meter square. And after her labs were done, her serum potassium was found out to be 2.2 milliequivalents per liter. And her serum carbonate was more than 45. So surely she is underweight. And after her labs were done, we can surely say that she was hypokalemic and has metabolic alkalosis. So we have to comment on what can be the most accurate cause of a condition. So first we will discuss about the differential diagnosis or the causes of hypokalemia and metabolic alkalosis. So we all know the most common cause is diuretic use. And the second most common cause is vomiting. Then we will discuss about the genetic causes of hypokalemia and metabolic alkalosis. The genetic cause include Liddle syndrome, which is autosomal recessive and usually present with hypertension. Then Barter's, Gentleman, and hypermagnesemia. Magnesemia. So, what can be the most accurate cause of the clinical vignette? So, she is a 16-year-old girl, a pubescent. She is a female. That's one. And after clinical evaluation, she was found out to be underweight. She is female, 16-year-old, and she is underweight. The likely cause can be vomiting. As we know, in a condition called bulimia, which usually presents in female more than a male in pubescent age, where the girl eats lots of food, feels guilt about it, then induces vomiting. And we know vomiting is the second most common cause of hypokalemia and metabolic alkalosis. So the likely answer can be vomiting. Let's discuss about the other causes. Why does hypokalemia and metabolic alkalosis usually present in diuretic use? In diuretic, mostly in loop diuretic or thiazide diuretics, there is inhibition of NK2's sodium chloride, sodium potassium 2 chloride channel and sodium chlorine symport, wherein there is inhibition in reabsorption of water and loss of potassium and acid, which leads to hypokalemia and metabolic alkalosis. The same is seen in Barter's and Gentleman. In butter, there is more severe hypokalemia and metabolic alkalosis than gentlemen, but the mechanism is same. In Bartter syndrome, there is inhibition of sodium potassium to chloride channel. In gentleman, there is inhibition of sodium chlorine to sympot channel, which leads to salt and water reabsorption inhibition and potassium and acid secretion into urine, leading to hypokalemia and metabolic alkalosis. We have to also remember that hypermagnesemia is also a cause of metabolic alkalosis and hypokalemia. So that's all for today.